Hi, this is Elliot Fishman, and welcome to our latest talk. And this is a talk that I gave just the other day at the American Association for Cancer Research. It was one of the plenary talks, the first evening, on the earlier detection of pancreatic cancer and the role of AI in radiomics. The session I was part of that Laura Wood put together was looking at many things that are looking at early pancreatic cancer detection. And so I'd like to share with you a slightly expanded version. This will probably be two parts. At the meeting, I had to cut down to 20 minutes. This will probably be 40 minutes, two parts. I do want to thank the Lustgarten Foundation, which supports all of our AI research, making everything possible. And Microsoft, you'll see, also supports us not financially, but with brain power and people. And together, we're all working on looking at a way of earlier detection of pancreatic cancer. Now, when you think about what's happened, 54 years ago, the first CT scan was done. Body CT came along about 1975. So we've been at this for 50 years. One of the most important things that CT accomplished was the evaluation of the pancreas. Previously, the way you would look at the pancreas was at surgery. You would look and say, oh, there's a mass, there's no mass. You'd do a diagnostic laparoscopy or diagnostic surgery to be more exact. When CT came along, we could see the pancreas, but in those days of 10 to 15 millimeter slice thickness, scan totals of about 30, scan times got down to 10 seconds, but initially were about a minute. The quality of the imaging obviously was not that good. Over the years, we moved along, we got faster. By the early 80s, we were at 10 seconds a slice. Mid-80s, 5 seconds. We got down to about a second in the 90s. We then came along with spiral CT, 4 slice, then 8 slice, 16, 32, 64, 128, 256, 512. And we are where we are now. We're at a point where the scan times are under a second. The slice thickness is not 10 millimeters, but under a millimeter. The host scan takes 5 to 10 seconds, and we talk about small lesions. We talk about lesions that are a centimeter, not that are 3 to 5 centimeters. Despite everything we've done, we still know that we have problems. The rate of interpretation error is up to 4%, and on studies that contain abnormalities, up to 30%. And this 4% number has not really changed, nor the 30% number. When you look at the pancreas specifically, 40% of tumors smaller than 2 centimeters are missed at CT. If you think about it, the smaller tumors are the lower grade tumors, grade 1, grade 2. Those are the tumors where survival is not 13% at 5 years, but it's more like 60%. If we could only detect even half the tumors we miss, we could save 15,000 lives or more a year just in the United States. So that's what we're looking at. Can we pick up the tumors earlier so that we can treat earlier? Remember, the only true cure for pancreatic cancer is still surgery. Yes, we use chemo and radiation therapy to shrink the tumor, perhaps make the tumor beds a bit more sterile, perhaps. We're working on all sorts of immunotherapies and new chemotherapies. Many things are being worked on, but still the only way to save someone's life is to get curative surgery. So we need to figure out something. Not a week passes where I don't see a case like this. This study is from 2 years ago. It was an outside hospital. Remember, mistakes are always made at outside hospitals, never your hospital. But there's a dilated pancreatic duct. There's some change in the caliber of the duct right here. It's cut off, and the gland is smaller distally. And you would have to admit that's abnormal, yet this was called normal. Do I see definitely the tumor? I think it's there. But the number one reason people miss pancreatic cancer is they don't call that pancreatic duct and say, wait, the pancreatic duct's abnormal. We better do EUS and biopsy. I'm suspicious. And sure enough, nothing was done. The patient had some mild symptoms. And now we're 2 years later, the pancreas is larger, the mass is larger, there's some early vascular involvement, the duct is seen, but now we have a patient who has a larger tumor, more infiltration, more spread around the pancreas. This patient eventually did go to surgery and we hope will do well, but you could see the tumor is still small, but 2 years ago it was there. Just imagine if we could pick up that first tumor routinely, what a difference we could make. Now, again, as I mentioned a few moments ago, the 5-year survival is based on staging, 12 or 13% versus roughly 60 or so percent. We need to find those smaller tumors. In the state-of-the-art talk, Kurt Landlatz, who was president of the RSNA at RSNA 2023, made the point for 4%, again, that 4% diagnostic exams contain significant errors, and he just basically said it's hopeless. We're looking at things like needles in a haystack. There's so many things that are just beyond our human capabilities. And then correlating complex multimodal clinical data sources, radiology, genomics, pathology, may be beyond human capabilities. But AI algorithms can perform these tasks. And so we need to look, and that's what I'm speaking about, AI. In this article by Tropathia, From Machine Learning to Patient Outcomes, a comprehensive review of AI in pancreatic cancer from this past year, AI can serve as a powerful tool in the advancement of pancreatic cancer diagnosis, management, and prognosis, particularly in identifying tumors earlier in disease progression. However, there are multiple limitations that must be addressed. Lack of a standardized approach to treatment and diagnosis. Other challenges include a lack of robust and high-quality data, transparency and reproducibility of findings, and ethical considerations, including bias in algorithms. Again, hope, but problems. Tripathi goes on to say we need to figure out to be able to pick up cancer earlier, as it is often diagnosed at an advanced stage when treatment options are limited. AI has the potential to aid in the early detection of pancreatic cancer by analyzing medical data and identifying patterns that may indicate the presence of disease. And that's what we're trying to do. Again, the last comment, pancreatic cancer is a complicated disease. Future research should concentrate on building algorithms capable of assessing and combining these disparate data sets in order to uncover strong molecular signatures, biomarkers, and therapeutic targets for pancreatic cancer. And we 100% agree. What we need to do is pick up cancer earlier. We need to figure out who's going to benefit from chemotherapy. We need better chemotherapy. We need immunotherapy. We need better surgery. We need a lot of things, but we are hopeful. Now, one of the things we've worked on, and I just spoke about briefly, was cinematic rendering, making the point that tumors can be subtle, as you can see in this case, where it was not recognized, though yes, you do see it. But cinematic rendering, by changing the texture, by changing how the pancreas looks and looking for any subtle changes, as you can see here, makes it easier to detect the presence, and you see it nicely on the coronal 3D of that 1.5 centimeter pancreatic mass. Now, the challenge is you need to know how to use cinematic rendering. The challenge, of course, is when you're using a texture, when you're looking at ways of changing how images look, You can also potentially obscure the presence of pathology. So with cinematic rendering, we need to get better at being more exact at detecting without over or undercalling the presence of disease. And we've been working really hard on that, and I think we are doing well. In this article by Javad, Pancreas Protocol CT is the gold standard in determining local resectability. And we talk about the role of post-processing. Post-process rendering, called cinematic rendering, overcomes the limitations we have by utilizing an advanced lighting model to generate photorealistic 3D images with enhanced detail. This article not only talks about detection, but talks about staging and preoperative planning. Now, the next thing we need to look at is radiomics. What radiomics is, in a simple term, when I look at a scan, I'm doing my visual assessment. Do I see something abnormal? Is there something there? Well, what if the CT scan is analyzed by mathematical formulas? The pancreas normally, a normal pancreas, should have a certain signature. And if the pancreas is abnormal, we're not going to say what the abnormality is right now. Its signature should be different. And the signature, we hope, of cancer is different than neuroendocrine tumors, is different than a simple cyst, is different than a serous cystadenoma. And so this idea of being able to look at the radiomics of a pancreatic mass becomes very critical. And in this article by LaPinta makes the point that it's not only detecting the tumor, but being able to predict the therapy and how to treat that patient. One of the things to think about with radiomics is done from CT scans. There's nothing special you do on the CT scan. It really is post-processing. What you're doing is when you have the scan, you go with feature extraction. You look at shape, you look at texture, you look at a range of filters. We typically use random forest filters, but you can use multiple different filters. There are literally thousands of parameters you can look at. We typically get down to between 5 and 10, and then we look at that and learn to predict clinical outcomes. This idea of inputting the scan, feature extraction, and analysis, looking at clustering, covariance feature selection, and looking at all that for clinical outcomes to teach us precisely what's going on so that we have a signature. In this work by Linda Chu, we talked about comparing pancreatic adenocarcinoma with normal tissue, that the signature was different. Think about it like a fingerprint. The fingerprint of cancer is different than the fingerprint of a normal study. And we had high sensitivity and high specificity. Now, one of the challenges, of course, with radiomics is there are many articles, not just ours, but articles on pancreas, not just on pancreas, but on liver, on kidney, on breast, on lung. What you see is there's an article written 50 to 100 cases, very high accuracy, and you never see a second article because there's so much variability in radiomics that it's very hard to be able to take what we develop and use it on another data set, surely from another hospital, where their scans differently, a different machine. Did they use a different contrast injection rate? Was the slice thickness different? All of these things affect the radiomic signature. Now, in our study, we looked at a wide range, and here's one of the other papers. We looked at a wide range of tumors. We looked at pancreatic cancer specifically, and again, thinking about these variable tumors, and again, a random forest technique worked very well. And when you look at the accuracy, radiomics-based pancreatic cyst classification was better than radiologists. Okay? So now we're talking not only being as good as radiologists, but being better, which is what we need to be, particularly on smaller tumors. And again, it's not only true in pancreatic cancer. I want to make the point that we've done work on neuroendocrine tumors as well, which shows that CT with radiomics is more accurate than biopsy for staging grade 1 or grade 2 and grade 3. Remember, grade 1 neuroendocrine tumors you can follow. Grade 2 and 3 get surgery. The reason it's more accurate than pathology, that's pathology for a biopsy, not after the patient's tumor has been resected. When you do a biopsy, you only have a portion of the patient's tumor. We're able to, with radiomics, look at the entire tumor. So when we think about radiomics, we think about detection, classification, and prognostication. In this article by Wang, making the point, CT-based radiomics based on the whole pancreas can distinguish cancer patients from healthy individuals and potentially become an early detection tool for pancreatic cancer. So now the thought is, and this is our thought as well, what if we were able to look at all scans? As soon as a scan was done, and let's say you picked an age of 30, radiomics was done on the pancreas, could we accurately detect patients who have early tumors or suspected of having tumors? Well, at the Mayo Clinic a couple years back, they published an article with radiomics looking at early detection. And what they showed, they used pre-diagnostic scans, which means a scan done, let's say 1 to 3 years before a patient was diagnosed with pancreatic cancer. Those scans, even when they were truly negative, radiomics in a significant proportion of the cases was able to pick up a tumor, even when the radiologist, even in retrospect, could not see the tumor. And here's 2 of the articles you should read that they published. But it now was saying that radiomics not only picking cases where the radiologist misses it, where you can see it in retrospect, but perhaps be able to pick up cases where even when the radiologist knows where the tumor is, they can't see it. Michael Rosenthal, reviewing those papers, made the point machine learning-based radiomics analysis may be a novel strategy to screen for pancreatic cancer by revealing changes in the pancreas that precede the development of cancer and the emergence of a radiologic detectable mass. That would be obviously spectacular. We did this review of radiomics in early pancreatic cancer detection. This is published in the Canadian Association of Radiologists Journal a few months ago. And again, making the point, radiomics can pick up smaller tumors. And again, we talked about radiomics-based classification model can achieve 100% sensitivity on several studies. Now, again, more work needs to be done, but I think it's very exciting. And again, when you think about radiomics, as I mentioned, it doesn't have the limitation of radiologists. It's looking at the entire image. It's basically a mathematical approach to medical imaging. It's this intensity histogram, statistics, texture features, shape descriptors. Again, this can all be done by the computer. And that's what makes it very exciting and very hopeful. I mentioned before, one problem with radiomics is the variability from site to site, but there is work going on. IBSI, Image Biomarker Standardization Initiative, trying to figure out how we could standardize these features and make certain that what I do at my site can be done at your site. And again, Pi Radiomics framework is the way things are being done. So there's lots of optimism that we could do things better and be able to do it more places. And again, in the article, there is a need for user-independent programs that clinicians can operate with ease. And to me, when I say with ease, you don't need computer scientists, you don't need radiologists. It needs to be done by itself. The computer needs to find the pancreas and then analyze the pancreas. And then you, as the radiologist, need to see the output. So again, it's very important. Radiomics has revolutionized the paradigm of early detection with promising results, but remains largely unused in clinical practice. It's bridging this gap, taking it from bench to bedside that we're working hard on. And our support from Lustgarten really is focusing in this area. Now, the next thing I want to speak about is classic, what you would consider AI. Can we have the computer find the pancreas? Can it find the tumor? Now, radiomics is part of AI, obviously, and in that situation as well, you're going to need to find the gland, not have the radiologist or trained technologist draw the gland, but really start after the computer finds the gland. So what I'll speak about in part 2 is what are we doing in this regard, and this will focus on a lot of the work we're doing with Microsoft, and I'll see you back here in a couple of minutes and we'll discuss it. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.